Hello and welcome to Make Your Life Healthy. I'm Patricia Sternkorb, and on this program tonight we have some really important guests that are going to be talking about women's health issues. And as we go through the program, there are some things we're going to talk about that if you have a squeamish stomach you might have to look away from. But we're going to be talking about women's health issues including hysterectomies, robotic surgery, why things happen the way they do, and we want you to stay tuned for what we've got in store for you because I know you're going to really find it interesting. So don't go away, we'll be right back. On today's program, we have two guests that are both doctors. They just happen to be husband and wife. Dr. Greg Owens is actually a urogynecologist, and his wife, Julia, is an OB and obstetric and gynecologist. So I have to get those terminologies right. And Dr. Lee actually graduated from the University of Texas Medical School. She was a medical honor student in the Society of the Alpha Omega Alpha, and she did her residency as an OB/GYN at Baylor College of Medicine in Houston. And then her and her husband met each other, and Dr. Owens actually was from the same school. He graduated from Louisiana State University, did his internship or his residency at Baylor College as well, and then he spent 2 years on faculty there before coming to Cincinnati. And he actually does surgeries at several different hospitals in the area. So we're going to talk to both of them. We started off this program just focusing on robotic surgery because it's such an interesting field, something so new, and we've kind of veered off, so we're going to be talking about women's health issues like hysterectomies, what causes them, and then some of the issues that follow that, and as women age, the problems that we have. So I know it's going to be a great program. So both of you, thank you so much for joining us today on this program. I'm so delighted to have you with us. And I know a little bit about both of you and the things that you're doing, and it just seems like groundbreaking information and technology. Who ever heard of a robot operating on somebody? That's one of the things we talked about. And you had to assure me that it's not the robot doing it. It's really you doing it. But before we even get into that, we're going to talk a little bit to Dr. Lee. You know, I found out that 1 in 3 women by the time they're 60 years old has a hysterectomy. Mm-hmm. And I had one myself several years ago, and when you think about that and you say hysterectomy, it's like, oh my gosh, what's wrong? You know, something serious is wrong if I'm going to have a hysterectomy. But it's such a common thing anymore. Mm-hmm. It's almost like a tonsillectomy or something. I mean, everybody has it. It's like afterwards, wow, what a great thing this was. Why didn't I do it 10 years earlier? So it goes along with the concerns and the health issues, but there are health issues that are related to it. Before you have the hysterectomy, of course, and then after, there are some issues, and of course you deal with those, Dr. Greg. So, Dr. Lee, I'm going to first ask you, what is the #1 reason that women need a hysterectomy?
I think in my own practice, I see a fibroid uterus as the most common condition when women would need a hysterectomy.
And what causes a fibroid tumor?
That's actually a genetic thing. So it tends, if you start asking women, it's like, oh yeah, my mom had that, or my aunt or grandma. So one was essentially born with the predisposition to have that condition, and typically
Really?
they tend to start like in their 30s or 40s. Mm-hmm. And once you get them, it tends to get slowly bigger and bigger. And the bigger it gets, the more symptoms women start to have, such as having heavy periods,
Right.
painful periods, so that makes them go to the doctor, mm-hmm. and we can actually find out the fibroids with the exam and pelvic ultrasounds and stuff.
And so when they come to you, and I know that was my issue, was I had a fibroid tumor mm-hmm. also, but when you get the symptoms of it, is there any other thing they can do besides the hysterectomy? Is there any other treatment you can do for it?
Well, the only thing that actually will remove the fibroid would be the surgery,
okay.
but there are other treatments that can treat the symptoms, such as if your symptom is mainly heavy bleeding, there can be something called the endometrial ablation, outpatient procedure like getting a DNC done,
okay.
takes less than 30 minutes. And then there's also something called a uterine artery embolization that's traditionally done by the radiologist in the X-ray department with an IV installation of this material to block the blood supply to the uterus, which can control the bleeding.
Okay, so for that symptom.
Right, and then lately we've actually used a lot of the Mirena IUD, which we insert into the uterine cavity, and that's a quick office procedure that takes less than 5 minutes that controls the bleeding.
Really?
But sometimes, you know, these procedures aren't 100%. Obviously, the results may be good as 80 to 90% success, but, you know, I'll see women coming back later because the bleeding eventually gets heavier again, where eventually they may need the definitive therapy, which would be the hysterectomy.
Okay.
Yeah.
Now, you see women all different kinds, obviously pregnancy, and you make deliveries. What's the number one reason, other than pregnancies, that women come to you?
I see a whole variety of conditions. There's a lot of infections like yeast infections, bacterial infections, women with pelvic pain, cramps during period. Let's see, what else?
Just a whole variety of
Yeah.
issues. Well, I know that when we're talking about the hysterectomy part, there's two different kinds, or maybe more. A full hysterectomy, when they take out the uterus and the ovaries and everything, or a partial. And there are advantages to both of those.
Right. So usually a partial hysterectomy would mean that we're leaving the ovaries and just taking the uterus out.
Okay.
And typically I like to do that in younger women that are less than 45 years of age. But if someone is over 45 or getting closer to 50, then I really talk to them about doing a full hysterectomy, just because the average age when the ovaries will stop working would be around 50, 51. So if they're already close to that point, I think that typically the symptoms would be less. And that way, if we at least get the ovaries out at the same time, that would reduce the risk of having ovarian cancer down the road.
Okay.
And ovarian cancer being the silent killer for women,
Right.
That would be one reason to push when the woman is older.
But when we're younger and they haven't gone through the change, if you take out their ovaries, they're going to immediately start going through the change of life.
Yeah, it would
And
be
so
a
that's
surgical
advantage.
sudden menopause, so hot flashes, night sweats, and
Okay.
stuff.
So does the age of the patient play the biggest part in what you determine if they need a hysterectomy or not?
Typically, unless there's a significant family history of ovarian cancer, then it doesn't matter how old the woman is. If she's done having kids, she doesn't need the uterus anymore.
Right.
So we could do the
Get rid
hysterectomy
of
even
it.
at 40 with the removal of the ovaries to decrease her chances of cancer.
Okay, very good. Well, we hear a lot about women's breast cancer and all the other different things and the surgeries that they have, but we hear very little about hysterectomies and why they're having them, or when there's so many having them. I guess because it's just become such a common thing, maybe, or it's so popular, I don't know. But is there really that big of a link between somebody having the cysts in their ovaries or the fibroid tumors going into cancer? Or is that like they're not even connected?
I don't know if I understood your question correctly, but
Okay, well, we'll cut that question. It's time for us to take a break. We'll be right back with Make Your Life Healthy, Dr. Lee and Dr. Greg Owens, so please don't go away. Welcome back to Make Your Life Healthy. On this segment of our program, we're going to get into some really interesting medical technology. And Dr. Greg Owens is one of the most proficient in the field of robotic surgery. Actually, Dr. Lee does a lot of it also. But Dr. Owens is going to walk us through a surgery. We were privileged enough to be able to go into his operating room, watch him do robotic surgery, and we actually can see the woman's inside as well as the outside. So he's going to walk us through what we go through on here. But I want to just ask you, first of all, the equipment, we talked about it ahead of time, and I told you a friend of mine had just had a hysterectomy, and she's like freaked out when somebody mentioned robots. She's like, I don't want no robot operating on me. And what did you tell me?
Not to worry that it's actually the doctor doing the surgery. The robot is just a tool. It won't do anything on its own, and it doesn't do anything without your permission.
And that's, I think, the big thing that scares women. It's like, what do you mean a robot? I don't want a robot operating on me. So we, when Rick went into the operating room with you, he was able to see the equipment, and it is huge. So if we're going to roll that footage, like they do on the Bean commercial, and you're going to see what's going on here.
Here's the robot. It's made by the Da Vinci company. As you can see, there's 3 working arms and a camera arm. They're all numbered, as you can see. The camera is in the middle. There's the number 1 arm is on the right. The second arm is the camera. There's a number 2 operating arm and a number 3 operating arm. The instruments fit into that little slot right there. The 4 oval pegs, as you'll see later, fit into the instruments, but depending on what you move with your hands, actually moves the instrument for you.
Okay, so this looks like really complicated equipment. Did you have a long learning period of how to use this?
Actually, yes, in that you have to do some online training.
Oh.
You do online training first, and that's mainly directed at becoming familiar with the robot, the electronics, the safety, mainly the safety features of the robot.
Okay.
Once you finish your online training, you go to an institution to do some on-site training where you're actually driving the robot. You spend a morning doing things like tying sutures or doing tasks like running washers around clothes hangers and things such as this, which seem kind of mundane, but it actually helps build a little hand-eye coordination. So after a morning of basic training, in the afternoon you'll operate on a pig, and you actually do surgeries all afternoon. You do a variety of things in order to actually get used to using the instruments, the electrical power to cut things, and to practice your stitching.
Amazing. And so you started doing this, how long ago did you start doing robotic surgeries?
Almost 3 years ago.
And your specialty is really pelvic floor dysfunction, so it's
Yes.
for women who have fallen bladders. Say some of the things that you...
Exactly. Fallen bladders is the main thing I see. Leaky bladders, which is very common. It's any type of benign gyn pelvic dysfunction. I don't do any cancer, but it's primarily things that have fallen down that are out of place, and because they've fallen down, it causes dysfunction. Can be bladder dysfunction, either lack of bladder control, leaking with coughing and sneezing, which is very common. It could be recurrent infections because the bladder has dropped and she doesn't empty. It can even be bowel issues where the rectum is starting to drop, and they have difficulties in that department as well.
So what percentage of your surgeries that you do are robotic surgeries?
Probably 40% of my surgeries are robotic surgeries, and I do the robots for the really severe prolapses.
Really?
Yes. And in light of the recent mesh controversies, there were a lot.
Talk about.
Yes, which we'll talk about later. There were a lot of vaginal meshes, and it was an attempt to improve the success rate of surgery, but what they found is they had more issues and difficulties putting in large pieces of mesh to the vagina. And that just reawakened the abdominal approach. The abdominal approach has been around for 50 years to pull things up. What's changed is the robot, and now you can do it and just an overnight stay. She's gone home, minimal discomfort,
Awesome.
back to her activities in 2 or 3 weeks. So the robot has revolutionized an old procedure.
And it's the healing that makes, the recovery portion of it is what does it well. You also do robotic surgeries. How many of your surgeries, percentage-wise, are robotic surgeries?
For the hysterectomy, I'd say right now over 90% of my hysterectomies are robotically done.
No kidding.
Right, yeah.
That is amazing.
Yeah.
And it's so interesting. It's just neat to see them. I know that the machine that they have here locally in our hospital is something that's fairly new. What made you decide that you were going to do this? Because I heard you were the one that said, I'll do it. Raise your hand.
Well, it started out with the hospital getting the robot. Obviously, we, as a surgeon, you're dependent on the hospital to have the instrument. So when the hospital bought the robot, then the hospital was looking for surgeons to use the robot for the surgery. So I thought, okay, I can get trained and get started. And I happened to have 2 patients that actually needed a hysterectomy. So we got things arranged, and I ended up being the first surgeon to do that at the hospital.
That's so cool. Okay, so walk us through a little bit more of it. Now you're telling us on here you're prepping the patient for the surgery.
Yes, the patient's prepped, and what you're seeing right now, the blue drapes are sterile. The camera is in through the umbilicus or belly button.
Okay.
That's where you make your initial incision. You put in a small needle and you distend the belly with carbon dioxide. Since it's an inert gas, you won't start a fire when you use electrical energy. So now that the belly is distended, you have to put in extra access ports, which you'll see are just little tubes that you can get instruments in and out. So what we're doing is we've marked the place for the port, and we're putting a little numbing medicine into the area where we're going to make the incision. Then you just make a small incision and you place the trocar into the belly, and it's basically a tube has a sharp end on it, and you guide it in while you're using the camera to watch what's inside to make sure you don't hit anything you shouldn't. And so these are placed at strategic points on the belly to allow the robot arms to move optimally.
Okay. And so that's what we're seeing here is you're prepping the patient, getting her ready for the robot. All this stuff you're still doing by hand.
Yes,
obviously.
there's a lot of preparatory work before you ever get to start the robot case.
Okay. Now, you have a couple of tools that you brought with us. So we're going to grab those before our next segment starts, and you can explain those to us.
Absolutely.
But we're also going to see on the next segment what the inside of the patient looks like and what you're seeing while you're doing the surgery, which I just thought was the most fascinating thing of all. So we're going to take a short break. We'll be right back with Make Your Life Healthy. Dr. Lee and Dr. Greg Owens, don't go away. Welcome back to Make Your Life Healthy, and I'm here again with Dr. Greg Owens and Dr. Julia Lee. And we're talking about robotic surgery right now in this segment of our program. Now it's going to get really interesting because we're going to see exactly what the robot does with the help of either one of these two wonderful doctors. And Dr. Owens, you actually brought some of the equipment with you
I did.
to show us what it looks like. Can you show the audience what this is?
Absolutely. This is a scissor, just like a regular pair of scissors one might use at home, only smaller. The blade's about 1 centimeter long, and this fits through the trocar, the little tube you saw us put in. There's a rubber seal to keep the CO2 from escaping. The robot interfaces with the tool here. These little dials attach or mesh with the oval-shaped pegs that you saw on the arm of the robot. That's how you can move it. You can move it back and forth, move the arm almost 360 degrees. The arm moves more than your wrist does. So if you want to get the full motion of the wrist, you have to take your finger out and re-grasp it. So this is a pair of scissors. In addition to cutting, you can also cut with electrical energy, and also you can also do what's called coagulation, which is electrical energy, which basically cooks the tissue,
And we
for
see
lack
that
of a better
on one of
word.
the
Yes,
sections.
exactly, and that's how you prevent bleeding. Is it with the heat, it fuses the tissue, it denatures the protein, causes the blood vessel to seal, and stops the bleeding.
So this is a little grabber.
This is a little grasper. It's a Maryland forceps. Usually this is used, since I'm right-handed, this is used in the left hand, and it's to assist and hold things out of the way so you can cut with the scissors in your right hand. This one primarily grasps and coagulates in order to prevent bleeding. The right hand does more of the actual dissection.
Okay, well, we're going to take another look at the footage, and I think the next segment is showing the camera actually going in, which we're going to see that in just a second on here.
Absolutely. So here are our ports. The big port in the middle is for the camera. The port to the right is the assistant port. And you'll see here's what the trocar going in looks like from the inside of the belly. There's a little black mark on the trocar. It's called the sweet spot. When you have your trocar like that, once you attach the robot and you dock it, the robot remembers where it is in space, and it rotates around that point so it doesn't tug on your belly. That's why people aren't very sore after a robot surgery as opposed to traditional surgery with an